much for joining us today as we review the results from the STI landscaping analyses that were conducted in East and Southern Africa this year. For background information, AVAC had its first STI sub-award program this year. We were able to support 7 organizations to conduct a landscape analysis that really explored the needs and ability to incorporate advocacy on STI vaccines and diagnostics into current and future prevention advocacy programs. These projects focused on chlamydia, gonorrhea, hepatitis B, HSV, human papillomavirus, syphilis, and trichomoniasis. And you can always learn more about these projects and the sub-awardees at the URL below, or you can scan the QR code. Just a note that these projects are incredibly extensive and they have a lot of information, and our speakers today have just taken a little bit of those projects to present. And so you might not see all of these pathogens discussed, but you can always go to the link below, and we'll also provide additional resources about these projects at a later date. So today we will have Lesotho, Networks of Aid Service Organization from Lesotho presenting. We will have Mamelo as our primary presenter for this one. We will also have the HIV Survivors and Partners Network from South Africa joining us today, with Mandisa as the primary presenter for this project. We will have Penge Zimbabwe AIDS Trust from Zimbabwe, with Cleopatra as our main presenter for this project. And we will have the Nyanza Reproductive Health Society from Kenya, with Simon as our main presenter for this project. And so then finally, you can always go to stiwatch.org to learn more about STIs and the work that we're doing at AVAC. And you can also subscribe to our newsletter, STI Watch, to stay up to date with what is happening. I am about to transition this presentation over to our presenters. I will provide their organization bios in the chat, and you should also use the Q&A function so that you can ask questions, which we will get to at the end of this webinar. And so with that, I hand it over to you, Mamelo. And Mamelo, if you're speaking, we can't hear you.
Hi, Alison. I think Mamelo wrote on the chat that she would like to be switched to being a panelist, if I'm not mistaken. Thank you.
Mamelo is a panelist, so she should be able to go. But also, Mamelo, if you need me to share your slides, please let me know. Okay, we might be having some connectivity issues. So Mandisa, are you actually ready to go to present?
Okay, you can. I can present. Maybe you can show from your side, because I don't want to take time to search my presentation. Will that work?
Yes.
Okay.
Here you go.
Thank you so much, Alison. Good morning, good afternoon, colleagues. As I've been introduced, I'm Mandisa Dukash. I'm an advisor for the project based in South Africa. This is the project team on the right. We're doing the STI landscape analysis in South Africa across 4 districts. This is just me. I'll turn off the video. Next slide, please. The project was conducted in South Africa across 3 districts: Free State, KZN, and Gauteng. The first thing that we did a desktop review just to look at the landscape in terms of STI prevention, the vaccines, diagnostic, with specific emphasis on regional and South African data. So that you can look at culturally and contextually relevant community-based approaches with regards to STI prevention, vaccines, and diagnostics. So we also conducted consultations across different districts, and there was one that was national consultations. We did focused group discussions with influential groups, and we also did stakeholders consultations, and those stakeholders included government officials, implementing partners, civil society organizations, and all these groups contributed their opinions with regards to the STI landscape. Next slide, please. So basically, the goal was to establish STI prevention, vaccines, diagnostic gaps, and advocacy needs within South Africa, even though we had to select a few districts to influence what we wanted to find out on the ground. So as I said, we reviewed policies that speaks to STI prevention and treatment, and guidelines that speaks to what is being done on the ground in terms of access to STI prevention services. We also conducted consultations with program implementing members, government, especially directors within the STI directorate, and implementing partners that are providing STI services and HIV services to establish what are the gaps in the prevention, in the treatment, and in vaccinations. So the focus group discussions were done basically or specifically with service recipients, because they had to tell us exactly what is it or what are the services on the ground in terms of the recipients side of things. The next slide, please. So I'll just be brief in the interest of time, but what we started with the inception meeting, which was a very, very informative session where we met with other 6 organizations within this project in terms of understanding what are the expectations and the timelines. The session was convened by AVEC in terms of giving us a guidance. And the desktop review was done by the team, as you saw on my first slide, where we're looking at what are the landscape within, emphasis on the regional and South African data, what are the initiatives, what are the services, what are the advocacy needs. So these are the things that we're looking at, and we documented the results of the desktop reviews that are part of our report. So the stakeholder consultations, we were looking at the gaps in terms of prevention, vaccination, and diagnostics on the ground. What are the gaps? What are the needs in terms of the service recipients? So we did with 25 district supporting partners, different partners in the different districts, where we knew these people are actually on the ground delivering services. They should know exactly what are the gaps within the service delivery context. We also did consultation services or sessions to understand the gaps with 65 civil society forum members in total, and representatives from the government department, 6 in total of the government department within the directorate of the STI. And the focus group discussions, which was the last that we conducted before the end of the project, where we actually convened the focus group discussions with school governing bodies and women with HIV and women at risk of HIV, where we wanted to establish their views on vaccinations, diagnostic gaps, and advocacy needs, and what are resources in terms of things that we can tap into in order to advance vaccinations. So we seek to understand the needs and perceptions of these groups and to document the current STI prevention and diagnostic advocacy gaps, and actually establish their opinions about HPV vaccination, the access, the risk of cervical cancers of different groups. In particular, from the STB, we're looking at young girls in schools, and from women of HIV, we're looking at their exposure to cervical cancer and what are the HPV access needs and advocacy needs when it comes to HPV vaccination. The next slide, please. So this is as a graphic of the consultation that we had, and when we were doing all these consultations and the focus group discussions, they would gather together, discuss, and come to present to different groups in terms of their opinions and their analysis. The next slide, please. This is also, the next one is just a graphic in terms of them presenting their data and their opinions as groups, different groups from different districts. The next slide, please, the results. So what we did, therefore, we sat down with all these pieces of papers, the flip charts, and we analyzed the data, and then we combined them into different themes. And when we took a look at the STI screening, testing, and diagnostic processes, one thing that came very strongly was that STI testing kits are not available. And even the government STI directorate, they actually confirmed over and above what we received from the civil society or the service recipients to say STI testing is not done. What happens is when you get into a health facility, you are complaining of maybe vaginal sores and whatever that STI symptoms that you have, they provide STI syndromic management. It's an umbrella management for everyone, irrespective of the kind of STI that you have. They cannot test specifically, which therefore, as we analyze that data and combine with the literature, we actually find out that that could lead to over and under treatment because people can be treated with something that they're not suffering from, or they can be undertreated because they're given treatment without being tested. And over and above the over-treatment, we actually assessed and see that there may be a risk for antimicrobial resistance. These are the gaps that we identified from the themes. So in terms of STI vaccination gaps and practices, HPV vaccinations or vaccines are available to young girls, which is something good, but that is only in public schools. This is not available in private schools. And one input from the SGB was saying in public schools for girls, but for boys, HPV it is not there. So as we are also saying that, as we were saying that some consultations was done with key and vulnerable population, sex workers, and then we're saying that the HPV is not accessible to the key and vulnerable population, which is a population that really is at risk of developing HPV. So women with HIV as well, they actually voiced out to say vaccination, it is not available. They do not have access to. So upon concluding and presenting to them and asking them exactly what do they think is their advocacy needs as responding to the gaps that they identified, that they mentioned that civil society, they have not been actively involved in STI literacy. Actually, they appreciated because before we actually started with the consultations, we would give them a landscape in terms of what is available, what is STI, what are different STIs. So they really said that they lack knowledge on the ground in terms of STI literacy. So in terms of knowing exactly what should be in place, they need to advocate, and they are promising to embark on advocacy to ensure that there's robust STI literacy on the ground. And the other thing that they think is a need for advocacy is because of this lack of diagnostics and access to vaccination. So they really think that they should have established or developed an advocacy plan to advocate for vaccination, especially HPV vaccination. The next slide, please. This one is just unpacking for the school governing bodies. The SGB is mainly members, I would say a governing body that is looking at all different services in schools. One thing that really came very strongly was HPV access in private schools and access to HPV vaccine for boys in public schools. That came very strongly. The second thing was comprehensive sexuality education. They said way before COVID, CSE was one of the programs that was supposed to be rolled out, but for now, in countries, there are certain provinces that are not rolling out CSE in schools. And one thing that really came very strongly was that policies, Department of Education, Department of Health, different STI and HIV prevention policies, they are not aligned. They're speaking different languages, and that is actually affecting sexual and reproductive health and STI services in schools. Then they really thought that there is a need for advocacy there. And school health services, they also said that, for instance, children are in school, they don't have access to STI services, STI screening in schools, but when they get to health facilities are very full. So it's really affecting them in terms of accessing STI screening and STI treatment. So they need to advocate for school health services that will bring STI prevention, STI vaccination, and STI treatment probably in schools, but depending on age of people that should be accessing those treatment. And lastly, the myths about quality of government condoms, because now, they saying data proves that condom usage is actually decreasing in country, which could be one of the reasons that young people are believing that government condoms, the quality is weaker than the condoms that they should be bought. So these are the things that said the STI literacy will actually assist in terms of improving the knowledge and access to all the services. The next slide, please. So this is the key things from the women with HIV and women at risk of HIV. As I highlighted earlier on, they really said that women with HIV in particular, they are dying of cancer. The numbers are increasing every day, and they do not have access to HPV vaccine in country. It's not accessible at all. So they are saying because of the number of women that are increasing, being affected with cervical cancer and dying of cancer, and very few areas where there is access to pap smear for early detection of cervical cancer. So with all those gaps, they really said that there is one organization that is led by women, that Positive Women's Network. They really said that they will gather more women with HIV in order to develop an advocacy plan which the HSP will actually assess them. So at risk of antimicrobial resistance and the pill burden, because now obviously they have a burden of being on treatment for HIV, and now without being tested for STI, but given a large number of pills without being tested due to the syndromic management, that is actually increasing their risk of AMR and also a risk of the pill burden. Lack of access to female condom was one thing that this woman, highlighted, especially female sex workers, to actually say they are contracting STI into over and above the HIV from their partners, because their partners or their customers, they do not want to use condom. If they were to have access to female condom, it would be easier for them to prevent STI. The next slide, I think that should be the conclusion, and then this is my second last, I'll wrap up. So one thing that we really want as a take home is that STI are acquired every day worldwide, and most of STIs are asymptomatic, and meaning people will not be treated though STI are in their bodies. And HPV infection is associated with many cervical cancers and cervical death each year, especially women with HIV that I mentioned. Many pregnant women, I think we all know that syphilis is the death of pregnant women because it's affecting a number of newborns or neonates, and some neonates are even dying because of syphilis. And STI have a direct impact on sexual and reproductive health through stigmatization, infertility, cancers, and pregnancy complications. And drug resistance is a major threat. I think this last one is very, very critical. So STI prevention, diagnostics, vaccines, costs, if we were to consider that, is much lower than dealing with the deaths that are associated with these STIs that we are not prioritizing screening and vaccination for, especially the antimicrobial resistance that we're starting to see now. We remember as HSPN, when we started this HIV advocacy, that we were told that HIV is not an emergency. This is the same thing. We're hearing that STI is not an emergency, but we want to say that STI is an emergency. And if we are not treating STI as an emergency, we'll actually risk to where HIV it is now with STI if we're not responding to the STI needs as a matter of urgency. The last slide. The call for action is that we need to scale up community-based STI literacy, establish STI advocacy technical working group. We need to roll out community dialogues and campaigns to raise STI prevention and vaccine access awareness, and advocate for point-of-care STI diagnosis, very, very key, and ensure there's access to female condoms and HPV vaccination in private schools. So all this call for action is one of the kind of interventions that HSPN is looking at embarking on to support all this on the ground advocacy group that highlighted all these gaps and the interest of being part of the movement moving forward. This is our last slide. This is just a team and the pictures of the team. I think, thank you so much, Alison, for sharing the organization information. People can just click and search about our organization if they are interested to know more about it. Thank you so much. Over to you, Chair. Thank you.
Thank you so much, Mandisa. Mamelo, are you available to present?
Yes, I'm available. Very sorry for the inconvenience.
We understand. Do you need me to share your slides?
Okay, you can help me share from your side. It's fine.
There you go.
Thank you, Alison, and thank you, everyone. My name is Mamelo Magwai, as it has been explained, and I'm working for the Lesotho Network of AIDS Service Organizations. And here are the names of the team members within the organization who were dealing with the project. Next slide, please. I would like to give a little background of Lesotho, especially in relation to STIs. Lesotho mainly as the country that has the second highest HIV prevalence at 22.7%, and we are the population of around 1.8 million. And we also realize that in our country, the social behavior change communication report indicates that there is no education on STIs, and culturally, it's a taboo to talk about STIs or even sex or sexuality or even reproductive health. So most of our health facilities are also owned by the church, and it's not very open to provide services like condoms, especially the Catholic Church. So while that is also happening, we also have high prevalence of HPV because it's a co-infection with HIV. And we also realize that we don't even have any documented research of STIs in Lesotho. Second slide, please. Yeah, we in schools, the country has started recently to talk about or to engage more in comprehensive sexuality. And culturally, like I said, the parents are still not free to talk to their children about sex. And general health education on STI is very limited. Accessibility to condoms is still a challenge because our terrain is also very bad, where there are people who are living without services at all. Some travel even long distances to access services. Community services are not really there. But the country now has exceeded the 1990 targets on HIV because programming on HIV is very strong, but for STIs, really, there's nothing much. Second slide, please. The project goal was to understand the community needs and landscape around common STIs in Lesotho. Next slide, please. The methodology here, Lenaso used the quantitative method, whereby we interviewed about 267 participants in the focus group discussions. These were people of different ages. We had 15 to 35, whom we had arranged in different groups of females and males, and we interviewed people in the community, we interviewed people at church, at health facility, district health management team, where we also interviewed the community health service providers and also the community-based organizations and civil society. Next slide, please. We also held one-on-one interviews with the Ministry of Health, where we met the HIV manager. We were looking much to talk to the STI program person, but we found that there's no designated person for STI, because even the people we know that were working on STI were no more working on STI program, but were assigned other diseases like HIV, TB, but not STI. So the public health nurse, we also met around the area, and the health center nurse we also talked to, and also we realized that most of the participants were men from the community, but at the community, at the health centers, they were mostly community health workers, but at the church also, the participants were mostly the adolescent girls. Next slide, please. Now, quickly rush into results. We had developed a questionnaire, and I will be talking to about 4 to 5 main questions. The question where we wanted to know whether they are aware of the STIs that are prevailing in their area, but the question was structured as such: do you know of any, or have you heard of any STIs? Most participants really knew about STIs, and they knew it in a general term that we use in our language to mean everything that is around the genitals that would happen, whether it's liquid or whether it's a sore or whether it's anything. They just knew that the term is called sore in our language. But when we dig deeper, we found that, okay, they mean gonorrhea for both sexes, female and male, gonorrhea, syphilis, HIV, pubic lice, HPV, chlamydia. But most male, they didn't really know much of the other diseases or STIs, because they were not even aware that HPV is STI. Next slide, please. We also wanted to know what is being done to prevent the STIs. Most men mentioned that they use condom, and they did not know of any other prevention method in the communities, because we really went to a rural district where the big constructions of dams and the mining sector, and the population density is very high there, but we went to the people who are residing in that community. So they didn't really have a lot of knowledge on STIs and prevention, but they knew that there are people who are there to provide condoms, and they knew about abstinence and faithfulness. But for women, most of them knew that there is PrEP, even though they only knew the oral PrEP. They didn't really know about the new methods or other PrEP methods. And they also knew that HPV vaccine is a preventive measure, and retention with U equals U, and faithfulness. Next slide, please. On this one, we wanted to know why is it that people delay to go to treatment, because as we were talking to them, they really mentioned that most people go to treatment when it's very late, especially when we got the reports from the implementers of cervical cancer care and treatment. They normally receive clients when it's at a very late stage. So we got the responses that they start with self-treatment, with local remedies. Some even seek treatment with traditional healers. Some are scared to be seen on their genitals, especially the young ones or the elders, when the service provider is a young woman or the person with the opposite sex. Some feel that it is because they may have conducted disease outside the family, and they are scared of the stigma or being associated with maybe prostitution or other things. While the females also added that it's because of lack of knowledge. Sometimes they would feel like it's normal to have that pain, but they wouldn't know that it's actually STI. They have to stand up and go to the facility. Some is fear of the health personnel, bad attitude, and lack of confidence also came up. And some also mentioned that for pap smear, they fear the equipment that they had is being used to examine them. Next slide, please. We also wanted to know of the norms and our cultural practices, how they influence the causes or may reduce STI, or what do they think about our cultural norms and practices. So both female and male, they said it's a taboo to talk about sex in our country. And I think that applies to most of the African countries. And they also mentioned that the positive side of it is that the way we are brought up, or they are brought up, is that the parents don't allow them to be going all over at night, or they not be known of their whereabouts, especially at night. So that protects them from conducting diseases from from their partners, or from being pre-exposed to diseases. Some said, the women said, actually, culturally, men enjoy tri-sex, which predispose them to tears and cuts that could easily predispose them to get infection. Next slide, please. Then we wanted to know the recommendations from their side. They said they need male health corners with the male service provider, because they are more free to talk as men to men. They also said there's a need for more STI screening and diagnostic projects in their district. There's a need for continuous condom education and demonstration to educate people around their area. And for the females, I'm sorry, it's male, it should be females. They need self-test for HPV because they have never seen it, but they heard that it's there in other countries and it's already being used. But they would really prefer to do it themselves. They need health education also on STI and prevention services. They also, the adolescents also mentioned that it would be good also to have peer-to-peer service provision, because most of the time when they get to the facilities, they get older people and they are not free to talk. Next slide, please. In conclusion, I would say there's still lack of general knowledge on STI to address the myths and the stigma. People are not aware of the prevailing services in their area, because when we were asking them, they did not know the partners that are there. They did not know of other things that are there. But when we met with the partners, they said they are there and they are providing the services even in that area. There's inadequate health-seeking behavior. From the interviews, we learned really that people still stay for a long time before they could go to the facility. There's lack of knowledge on patients' rights, because for the fact that they still fear the attitude of the health professionals, they still lack confidences, because they don't know that it's their right to seek for services, for any service. There's also lack of accessibility for most of services, especially looking at our terrain. In the remote areas, some people don't even get services at all. Some travel long distances to get them to the health facility, and they can't be traveling only to go for a condom to the health facility. But if there are condoms all over the place, that could help them to prevent themselves from getting STIs. There's lack of research on STIs and documentation on STI. We tried to talk to our national research committee, and we also worked with the senior research officer, who told us that there's no research at all on STIs in our country. Next slide, please. There is also a need for research, like I already mentioned, there's a need for engagement of civil society organizations to innovatively design and implement peer-led services so that services could be accessible in the communities. There is a need to improve advocacy for prioritization of STI in the national strategies or national agenda, because currently in my country, I don't think that is taken into consideration much. I only saw it coming up very strong in the Global Fund proposal now. So there's a need for more advocacy. There's a need to advocate for and influence policy changes to improve on STI interventions that are community-led. There's a need for advocacy also for availability of acceptable and affordable integrated STI services in the communities, so that the people could not only go for HIV services in the community, but when they have STIs, they would be returned to go to the facility, which is a bit far. There's a need to inform targeted STI prevention and treatment interventions. Next slide, please. Thank you. Here are the contacts for in case you want further clarification. And I would like to thank AVAC for the opportunity and thank everyone. Thank you so much.
Thank you so much, Mamelo. And I see there are a few questions in the chat. So these presentations and slides will be shared later this week or early next week. So folks should have access to them. And with that, Cleopatra, we turn this over to you. Do you need me to share your slides?
Yes, you may share, Alison. Thank you.
Okay, there you go.
Thank you so much. So my name is Cleopatra Makura, and I'm a program officer at Pangaea Zimbabwe AIDS Trust. Next slide, please. Sexually transmitted infections continue to be a major public health problem in Zimbabwe. And from the data that we have looked at from our demographic health survey in 2015, it showed that 8% of the sexually active men and women had reported either having an STI or experiencing some STI symptoms. And among those respondents, 48% of the women and 55% of the men had not sought any advice or treatment. And the graph there shows that we still have high numbers of vaginal discharge as well as urethral discharge. And we all know that if left untreated, STIs can lead to severe health complications, which are some certain cancers such as cervical cancer, as well as the pelvic inflammatory disease, and can even lead to infertility. Next slide, please. And our objectives mainly were to identify the gaps and unmet needs that could impact the successful implementation of STI prevention and management programs. And we also wanted to understand the opportunities and threats that may impact the implementation of STI prevention and management programs. And we wanted to identify existing assets in the community that could support the implementation of STI prevention and management programs. We also wanted to come up with key recommendations that can then strengthen STI prevention and management programs in Zimbabwe. Next slide. We conducted a qualitative assessment, and we collected our data through focus group discussions and some semi-structured interviews with key informants. And our participants were really asked around STIs testing, prevention, and access to testing and treatment services. And our focus group discussion participants and the key informant were drawn from the 9 provinces in Zimbabwe, and we focused on the 9 districts from these provinces. And we conducted our data collection activities on the 18th, from the 18th to the 24th of September. And our data was analyzed by developing codes. And we also ensured that we recorded the sessions and received verbal consent from the participants, and we transcribed these into Word scripts. And we also then coded initially for transcript to identify emerging themes. And then we compared this across sites to ensure there was consistency. And then we refined the coding framework in Microsoft Excel. And that was at that point that all the remaining transcripts were then coded using the Microsoft Excel code sheet. And then the initial codes were then mapped to develop broader categories, which then allowed us to then distill the meaning of the data in context according to the questions that were asked in the guides. Next slide. These are some of the subgroups that we identified. So for each province, we then identified a different subgroup. So we had adolescent girls and young women from Matabeleland South, and adolescent boys and young men from Mashonaland East Province, as well as sex workers from Harare, pregnant and lactating women from Mashonaland Central, persons with disabilities from Mashonaland Province. And we also had conversations with men who have sex with men and transgender persons in Bulawayo. And we also talked to men who are touts or artisanal miners from the Midlands Province, and women who are into informal or formal traders from Manicaland, as well as faith-based women in Matabeleland North. And for our key informant interviews, we also talked to community-based organization representatives, as well as the Zimbabwe National Family Planning Council and the Ministry of Health and Child Care, and some representatives from the National AIDS Council and other civil society organizations in those working in those provinces and districts. Next slide, please. So on to our findings. You might find that on the profile of our respondents, most of the participants at the sites were single and had attained some secondary level education. And some of them, like I highlighted in the previous slide, were running an informal business, and some of them were casually employed. And you might find that we had most of our participants from the pregnant and lactating women who were 19, followed by the sex workers, as well as the faith-based women. Next slide, please. So some of the key drivers of the transmission of STIs, we also noted that there's low risk perception among respondents despite having basic information on STIs. And the participants, despite showing that they have basic knowledge and information, their responses indicated a limited understanding of the complications and challenges that are associated with contracting an STI. And respondents were then able to name some of the STIs that were common, and some also used the syndromic approach, but a few participants were aware of the genital warts and candida as well. And we also noted that there's low health-seeking behavior among persons who then contract STIs. And despite confirming that cases of STIs are on the increase, participants highlighted that coming forward to access health services from facilities is difficult. They also highlighted that people who contract STIs tend to be secretive and shun away from getting help. And most of the subgroups that are then affected by STIs are not then forthcoming in presenting themselves for services. And some of the reasons they cited were lack of confidence in the health system and conditions to then access services, including user fees. And we also noted that there's an economic vulnerability as a key driver to STI transmissions, because some of the respondents highlighted that persons that are economically vulnerable and engaging in transactional sexual activities have a high risk of then contracting STIs. And generally, most individuals who are in this predicament are at risk, and there are some subpopulations that are then affected, which include the sex workers and some populations that then sell sex. And this is also highlighted on one of the quotations that we've highlighted, that when one of the participants was noting that if there's a wealthy client who offers money and does not want to use a condom, then they will then comply. And we also noted that the risk of contracting STIs in committed relationship associated with low health-seeking behavior. There were some respondents who also noted that multiple concurrent sexual partners among persons in committed relationships is one of the key drivers of STI transmission. We all know that patriarchy still continues to have a negative impact on the context, mainly for girls and women engaging in high-risk sexual relationships with multiple partners. We noted that once symptoms begin to emerge, individuals then access treatment on their own and neglect disclosing to their sexual partners or linking them to care. And we also noted that there's an intersectionality that is between the use of drugs and substance abuse, as well as the risk of contracting STIs, because there were concerns that were raised over the increase of drug and substance abuse in some target locations. And people who use and inject drugs have become innovative and are using various chemical components from the existing drugs. And we have noted that once someone is intoxicated, in some cases, they then engage in high-risk sexual activities, resulting in the transmission of STIs. Next slide. We also noted that issues around access to STI treatment, care, and management were also raised by the respondents. And one of the issues that was raised was access to treatment of STIs through unofficial channels. So there were respondents who actually noted that they do get their STI treatment drugs in management services through unofficial channels where they don't really go to the health facility, but rather they get the services from a healthcare provider, but not in a health setting. And we also noted that there's STI-related stigma in accessing health services, because some of the participants actually noted that they are not comfortable to actually go and get STI treatment or services, especially those who are in long committed relationships. They noted that they are scared to be asked questions like, how did you get an STI when you are in a committed relationship? But then we also noted that sex outside of marriage is socially frowned upon, and hence the STI-related stigma is very much across communities. We also noted that people reported long waiting periods at the healthcare facilities, and this was when participants were revealing that they preferred quick access to STI treatment at the facilities, but their reality, however, was that access to health services in public health facilities usually took longer. And for some respondents, the long waiting periods were attributed to the negative attitudes by some of the health personnel. And they then noted that they take long periods in attending to people who would have visited the health facility. And some of the participants noted that they actually use traditional herbs to treat STIs rather than using the drugs that they get from the health facility. And they were noting issues around cost, to say that traditional herbs are more cheaper and easier to access, than accessing services at a healthcare facility. And they also reported poor quality of care from the health professionals. And they also noted that there's high cost of STI diagnostics, treatment, and management services. And these are the user fees. And some reported that actually getting a service could cost someone an amount of up to about $10 or more. And some of the young respondents, young people who also took part in the focus group discussions, noted that parents or guardians act also as a barrier to accessing STI services, as they noted that they have that fear to be known that they've actually accessed a STI treatment at a facility. So they wouldn't want their parents or guardians finding out that they have contracted an STI or they've actually accessed STI management services. They also noted that the disclosure and index case findings for STI treatment also act as a barrier to accessing STI treatment. And this was attributed to the fact that when you contract an STI and you want to access services, you might be asked to then come with your partner. But then some of the respondents were noting that they might not be able to then have access to the partner, or they might not even have information on which partner which they would have had sex with and had contracted that STI. And they also reported drug stockouts at some of the health facilities as a major cause to lack of access to STI treatment. Next slide, please. Generally, we noted that most of the respondents, including the key informants, were not aware of most policies or strategic guidelines that inform the national response to STIs in Zimbabwe. And the knowledge gap is really worrisome because policies and strategies are what then drive the response to public health issues. And STIs is a key component, including national strategies and guidelines, which are then primarily focused on HIV and access to care. We noted that there's lack of community programs specifically for STI prevention, treatment, and support services, because most interventions for STI have always been mainstreamed with other running programs responding to HIV. So most of the key informants actually highlighted that while the strategy has worked well in the past, there's a sharp increase in the incidents, and the trends are showing how this approach is no longer working, and there might be needs to actually mainstream STI programming and response as single programs. Next slide, please. So some of the gaps and unmet needs that we also noted were that there's prioritization of STIs within a coordination platforms for health at all levels, including technical working groups. And we also noted that there are strong movements driven by civil society working towards universal access to STI prevention, treatment, and care. And as part of some of the opportunities, we noted that there's acknowledgement by the government on the need to strengthen the response to STIs. And there's also availability of best practices on linking communities to health services, including the differentiated service delivery models, outreaches, and health literacy programs. And there's also availability of technology and virtual platforms to engage communities and facilitate access to services. And some of the threats that we then noted were that there's existing STI, the existing STI is related to stigma and discrimination by health professionals. And the health systems continue to deteriorate with issues centered on the attrition of health workers, availability of medicines, and insufficient medical equipment in some of the health facilities. And there's also lack of coordination and an overall strategy in responding to STIs beyond the HIV response program. And we noted that as part of the strengths and the assets, We already have a strong base of civil society organizations in their diversity who have done well in complementing the response to HIV among other public health systems, among other public health issues. And we also have the government operational structures that have already included the response to STIs as a core program area, including the use of community and village health workers. And there are already coordinators and support workers that are also available at national level. Next slide, please. And some of the recommendations that we noted were also that there's need to then unlock resources that are needed to ensure that communities have access to STI literacy, diagnostics, care, and support services. And we're also calling for a responsive system and processes that then address in the continuum of care, including mitigation strategies against drug stockouts, and also contribute towards the development, availability, and utilization of biomedical STI interventions. There's also need to then build a strong movement of stakeholders, inclusive of communities, that facilitates the sustained commitment and a collective mission to address some of these barriers, the gaps, the challenges that are related to the access of STI prevention, treatment, care, and support services as a whole. And there's need for efforts that should be targeted towards creating a culture of providing high quality services where confidentiality is upheld and access to services is also non-judgmental. And finally, strategic investments should be made in designing new models and borrowing from approaches that have worked in responding to HIV, focusing on mental health, and also using digital platforms to raise awareness. Next slide, please. Thank you so much. And these are some of the contacts that you can use if you would want to get in touch with us. Over to you, Alison.
Thank you so much, Cleopatra. That was a really great presentation. A reminder to all of those on the call, you can add questions to the Q&A box or the chat, and we will go over them once Simon finishes his presentation. So Simon, I hand it over to you. Do you need me to share your slides?
Especially for members of the lower chamber in the U.S. Congress, the House, who face elections in November.
Thank you, Alison, for the opportunity, and thank you everyone who's presented before me. This is Simon Odiwuor from Kenya. I was based at the Nyanza Reproductive Health Society, where I was conducting this landscape mapping analysis from. As the title suggests, we are doing the landscape analysis of STI prevention in Kenya. And I hope everyone can see my slides, my screen.
We can see your screen, Simon. It's still just in the regular presentation. It's not in the presentation mode, I mean.
Oh. Okay.
Yep, that's perfect.
That's better now. About this project, the little background that I'm going to share will be, we were coming from a global perspective, and definitely we know that over 1 million STIs are being transmitted daily. And we know that a majority of these are being asymptomatic, meaning they show no symptoms. And when someone shows no symptoms, it's easy for them to keep transmitting the infections as they have unprotected sex. A lot of the STIs that we come across are either caused by bacteria or viruses or parasites, and lastly, fungal infections. And we can see that despite the global efforts, STIs rates still remain high. What do we see about what is the impact of these increased STI rates? It has impacted a lot on health and economies, and we know that most of our countries, East and Southern Africa, inclusive, who are members of the LMIC, are very much impacted. And the fact that these, like I said, through the STIs are transmitted through sexual contact, and the effects that they cause include increasing HIV risk and adverse reproductive outcomes. For example, when we talk about the impact on economies, we can see that in 2016, 4 common treatable STIs caused an estimated 376 million new cases. Look at that. That's quite a number of new cases to deal with. The risks that these STIs can cause, other than increased risk of contracting HIV, we can see it can cause stillbirths, neonatal mortality, low birth weight, preterm birth, sepsis, and congenital abnormalities, among others. In Kenya still as one of the LMIC countries, we still face a higher STI infection rates, and especially amongst young women and key populations, including sex workers and MSMs. The common STIs in Kenya include chlamydia, HPV, gonorrhea, bacterial vaginosis, and HIV. And one thing that we know, one challenge that we have is reaching key populations and young people, especially with the youth-friendly services. This gives us the challenge, especially when we want to really design advocacy programs. One, we need to focus on the high costs of diagnostic tools, because if they are not reachable, the prices are so high, then even people who need these services or need these tools will not be able to get them. Two, we need to preach about antimicrobial resistance. One thing about antimicrobial, about this is because a lot of people go over the counter and just buy antibiotics and take whenever they feel symptoms of any infection, including STI. And these, in the long run, will definitely lead to treatment failures and or severe health outcomes. We also need to talk about asymptomatic cases. So our advocacy programs need to target asymptomatic cases. Why? Because people need to know how to really, the basic signs that they can. If they have unprotected sex with their partner, they need to understand that they go for testing or screening, or else they will be unknowingly transmitting the infection to others. So we need to probably encourage safe sex, or which includes use of condoms, to protect those you care about. Another issue that we saw this project come across as a challenge will be access to STI prevention and care service. A lot of populations complain, but this is a major problem in our country, especially when it comes to young adolescent girls and young women and the key population, sex workers, MSMs. But also we have a particular problem in the rural areas and or informal settlements of Kenya, where services are not either non-existent or are far off placed. We also needed to look at the scalability of these interventions. Make them available, make them accessible, and expand them to reach populations that can. The goal of our project was to conduct a landscape analysis for vaccine, STI vaccines, and diagnostics, and hopefully identify opportunities for advocacy, like in my previous screen. So we were looking at existing efforts for STI vaccines. We were looking at the gaps, the challenges, and the barriers to STI advocacy. We were also looking at mapping key stakeholders who are either doing something currently around STI prevention or are willing to work with in the next future to prospect to become partners in working in STI prevention. We were also evaluating current strategies that exist, including awareness creation. How did we do this? Our methodology included a mixed method research approach, where we used key informant interviews, we used FGDs, and we also did document reviews to gain background information on the current status of STI prevention in Kenya, or the impact of STIs in Kenya. Our sampling included purposive sampling, and when we did purposive sampling, selecting participants based on their expertise in STI prevention and advocacy, and their unique perspectives in STI prevention. We were also looking at participants who are playing critical roles in STI prevention, including managers. We were also looking at the demographic and geographic diversity, and as such, when you see we stratified our country into 3 regions to make sure that we achieve this geographic diversity. And allocated our interviews. We conducted 15 KII interviews and 3 FGDs in total. And so we allocated these 15 interviews proportionally into these 3 regions. And why did we divide these regions into 3? We wanted to make sure, because we know that different regions have distinct burden of STIs. They also have varying levels of advocacy efforts, and also the process unique challenges. Like in the coast, the adolescent girls coast, the coastal region of Kenya is more Muslim based, and it's a patriarchal society down at the coast, and so sex is not something that you talk about easily. And so how do you expect young girls to really access these things, or to approach their parents when they feel, or maybe you wouldn't want to be known that you're sexually active? And so a lot of young people will be hiding behind the cultural rules. So that's what we came across. The FGDs were very specific to different populations. One was looking at adolescent girls and young women. Another one was very specific to sex workers, to gain their perspectives and their experiences around STI prevention efforts in Kenya. And then the last one we did with men having sex with men, to also get a perspective of what do these key populations, what are their perspectives around STI prevention in Kenya. Most of our data collection methods included KIIs and FGDs, like I mentioned. And with KIIs, we wanted to gather insights from experts, and also with FGDs, we were looking at capturing community level insights and challenges. With document reviews, the third one was document reviews, sorry, not key informant interviews. We were looking at existing literature and documents and providing background information that addressed the research questions. Our scope was to engage a wide spectrum of stakeholders. And like I said, we did it from policymakers to healthcare providers and to community representatives, as well as to international organizations and experts in sexual and reproductive health. We also looked at funders of civil society organizations and research organizations. Looking at what we came up with, our results were organized into 7 themes, and we can see all the themes there: our perception of STI prevention, existing STI vaccines and diagnostics, perceptions of advocacy landscapes, successes and opportunities for advocacy, gaps and challenges in advocacy, community stakeholder engagement, and innovations and solutions. What we came up with is that a significant portion of our population, especially in rural areas, lack comprehensive knowledge about various STIs and the available prevention methods. A lot of these populations were not even aware that we have an HPV vaccine that is being given to people out there. We also identified that access to these tools, both vaccines and diagnostics, were hindered especially by geographical distance, financial barriers, because if you are not, most sex workers and MSMs and adolescent girls are able to access these services at what we call DICEs, or drop-in centers, and these are funded places. But the other option is to go to public health facilities to access these services. And when you attend these public health facilities, then you have to be able to pay for these services. But in the diocese, services are free, and also they're user-friendly. But in public health facilities, a lot of these populations were complaining that there's a lot of stigma and discrimination that exists, and so they wouldn't want to go there. Well, effectiveness of these prevention initiatives were also one thing that we found was worrying among us, the populations we talked to. But a lot of these key individuals called for stronger government coordination that should be led by the main called NASCOP. And they also felt like we need to do more research so that we get to have data-driven advocacy in our country. But they also felt, a lot of people also felt that it is time to integrate STI prevention with broader SRHR efforts in Kenya. Let's not have HIV working on its own. Let us not have family planning working on its own. Let us not have cervical cancer working on its own. Let us not have STI working on. Let's marry all these services together and we push the efforts together. Next is sorry. We came, like we talked about stigma and discrimination among key populations, and it hinders the uptake of STI testing and treatment, especially in public health facilities. We also felt there were no limited political prioritization and cultural norms in our country. But one thing that came across is that government health departments, NGOs, and healthcare providers really play a pivotal role in STI prevention, and these need to be encouraged, especially in advocacy and service delivery. There needs to be a collaboration and community engagement. A lot of groups we called say we need to synergetical kind of push. We need to come together, different organizations doing different small things. We need to come together and push the STI agenda to the forefront. We need, as we do this, we have to be very sensitive to different cultures across the country so that we do not really step on anybody's toes. And we also need to make sure that when we want to talk to adolescent girls and young women, we need to work with them. When we want to talk to sex workers, we need to involve them in our planning and strategies. When we talk to MSMs, let's not leave anybody. Let's not develop programs for a specific target group, yet we do not work, we are not part of the planning processes. So we need to bring everybody on board. And so to ensure that our efforts create the needed impact at the community level. But another thing that came up very, very key was the use of technology in service provision, in creating forums, safe spaces for our communities so that they can access STI prevention information. We need to probably develop apps or create games that people can play and learn about. Another issue, because that came up and was pushed by a lot of the people we talked to, was the issue of how can we be able to test ourselves at the privacy of our rooms like we can actually do at present using HIV. So we need to find a way, can we work with the private sector to develop self-testing kits and be able to like the HIV self-testing kit that will increase testing, it will increase awareness, it will increase knowledge of our status. As we move towards the end, most of our key takeaways from these analyses was that there are significant opportunities to improve STI prevention, especially in ensuring equitable access to vaccines and diagnostics. and probably to advocate for SRHR in Kenya. And this will happen through policy changes. One policy change that was pushed for, especially encouraged, was we need to lower the age of sexual education in our schools, because in as much as we can't talk of sex below 15 years, yet children as young as 10 years are getting HIV positive or getting STIs, are having sex, sexually active. But in schools, the education policy doesn't allow us to talk about sex in these schools. And so partly that's one of the policy changes that needs to be changed. We need to enhance community mobilization, and also we need to encourage public-private partnerships in STI prevention. But the other one is to develop comprehensive educational campaigns. Such challenges that we came across, like limited public awareness, disparities in information access, and stigma and discrimination, still exist. And what does this tell us? That we need to develop focused advocacy efforts to really bring everybody on board, to create the needed awareness. One issue that we need to about STI prevention and efforts in Kenya include, we need to develop encourage supportive government policies that prioritize STI prevention and equitable healthcare access. We also need to ensure that when we work with different community-based organizations or civil society organizations, we develop capacity building programs, not just for them, but also for healthcare providers, because we need healthcare providers to be user-friendly and encourage individuals to come for healthcare services, or to be able to deliver inclusive healthcare services to our populations that need these services. Lastly, but when we address project limitations, we want to be able to work collaboratively, especially with the government leading at the forefront. A lot of people that we worked with, especially the organizations that we engaged, especially in our FGDs and KIIs, included the ones that have been listed. But the main acknowledgement goes to the three that we partnered with in this project, including funding from EVAC and technical expertise from NHS and approval from NASCOP to conduct these STI analysis in Kenya. Based on that, I want to say thank you for the opportunity to present my work to everyone. And if anybody needs more information or any other discussion, my contacts are there. Thank you. Listen.
Thank you so much, Simon, and everyone for your presentations today. I'll remind our attendees that you can include your questions in the Q&A box or in the webinar chat box. And so just to start us off, I will ask our panelists today, what are some next steps that you would like to see taken to better address STIs within your countries? And Mandisa, we can start with you.
Thank you so much, Alison. I think as alluded by a number of my colleagues, one issue is really access to vaccination and diagnostics, which seems to be a problem at a regional level. And over and above that, knowledge about STI in a number of communities is quite challenging or is lagging. So these are the two things that I think at a regional level, one is scaling up STI literacy about vaccination and prevention methods, and even symptoms. That's very, very critical. Number two, a multi-sectoral advocacy structure and research. These are the things that I really think should be the next step of these advocacy organizations. And obviously, there's a need of investments because over in the, throughout the years, we've seen investments in HIV, TB, and all other illnesses, but STI has been neglected or ignored for a number of years. Thank you so much.
Thank you. And Cleopatra, the same question. What do you think are some next steps we can take in better addressing STIs?
Thank you so much, Alison. And just adding to what Mandisa has alluded to, I think there's also need for investments that actually design new models, and we can actually borrow from some of the work that has been conducted in responding to HIV, but we should also have a special focus on mental health, and we can actually think about the digital platforms that we can use to raise STI awareness. And there's also need to ensure that when we are responding to STIs, we build a strong movement of stakeholders. So this should be inclusive of the communities, the healthcare providers, from the provider up until to the end user, including the policymakers, so that we actually have a holistic approach when we are responding to some of the gaps that have been alluded. And we also need to take advantage of the new technologies and the research that is being conducted, and our countries should be able to adopt the new strategies in responding to STI care and treatment, as well as STI prevention. Thank you.
Thank you, Cleopatra. And now to you, Simon. What do you think are some of the next steps to addressing STIs?
My next steps, and especially the ones I have covered a few in my presentation. One is to encourage collaboration and partnerships among stakeholders, and to share best practices and combine resources to amplify collective voices and strengthen advocacy efforts. We also need to explore and implement innovative approaches in our advocacy and in our prevention efforts, like develop mobile apps for for STI prevention, and like what I mentioned, self-test kits for testing kits for STIs. We also need to develop online platforms, create online platforms where people can freely share about their STI issues. Another main issue is to address resource constraints in our countries. We need to, these include financial, human, and infrastructural resources. This will help in implementing, say, comprehensive STI prevention advocacy efforts. I also mentioned in my presentation that we need to integrate STI into a broader SRHR initiatives for more comprehensive impact. Let's not leave STI as one of the sons. We need to bring them into the fold. We need to encourage research organizations to conduct more research together to generate more evidence. We also need to make sure that our healthcare providers, they will mention so much as a barrier to service uptake. So we need to meet with them and train them, so that they can have inclusive skills, reduce stigma, and improve service quality. Lastly, we need to encourage public-private partnerships, especially in improvement of STI diagnostics, and in the development of the apps and online platforms that we mentioned. If we do not bring them in, we might not really fail. But lastly, we also must ensure that we do comprehensive campaigns and advocacy to enhance public awareness and knowledge about STI prevention methods and the availability of such tools like vaccines and diagnostics. Thank you.
Thank you, Simon. And Mamelo, what do you think are some next steps to better address STIs in your country?
Thank you, Alison. I think the main thing would still be to address the barriers. We are very much aware that our people start with the traditional healers. So there's a need to engage them, to plan with them, to raise that awareness, and to try to also work on on the stigma and working together with our health professionals as well, and to build that confidence, especially in women, because we realize that they delay to seek for services because they are scared of themselves. They fear the health professionals, they lack that confidence, they fear their partners and all that. So we still need a lot of that advocacy at community level. We need to engage civil society more and peer-led models that would address peer-to-peer. If it's a sex worker talking to a sex worker, adolescent talking to another adolescent, a male to a male, and all those innovative strategies that civil society could bring up, they need funding. We need more to work on the research. We need that evidence to be documented because like in my country, as I have explained, I tried to look for whatever research projects that have been done around STI, but there was actually nothing. So we need funding for research. And for diagnostics, there's a lot that we really hear from other countries, but in my country, I think we are still left behind a lot. We need to advocate for a lot of other things. Self-test for HPV, it really came up very strong, and we would like to advocate more for such diagnostics. Thank you so much.
Thank you so much. And for our last question, I know that a few of you mentioned AMR, and we had Barbara Friedland in the chat who also found AMR a really interesting topic. So do you guys have any thoughts on how we can better address AMR or how to better prescribe antibiotics? And yeah.
Responding from the South African perspective, Alison, I think one of my colleagues mentioned the issue of research, because we know there is a rising numbers of MNR, but there is no data that can be used to influence on advocates for ways of better prescribing antibiotics. So the first step will then be to have a community or implementation research, that community-based research, that can actually look at those cases. That definitely requires some funding and technical expertise in terms of identifying those cases in community facilities in order to influence changes and probably methods that can actually improve and mitigate those impacts. Thank you. I think that's my opinion.
Is done. I can add a little bit on MR and how better to address AMR in the context of STI prevention. One thing that I know we need to do is probably establish a surveillance system to monitor the prevalence of AMR in STIs, meaning all people who come in for STI treatment need to be surveyed, to be tested, and for data to be collected and analyzed to identify trends and probably emerging resistance patterns. I'll also think that we need to ensure that healthcare providers probably follow best practices to minimize the risk of resistance. They need to be able to, when treating and probably prescribing medication, they need to really follow best practices. Another thing that we need to do to address AMR is to conduct campaigns, educational and awareness raising campaigns, both amongst health providers and both amongst in the communities. People are going for these medications, especially about the importance of responsible antibiotic use and the risks that AMR will pose for us. The moment you become resistant, then no, those drugs will not work when you really need them. Another thing that we need to encourage is let's probably have research around new antibiotics and probably alternative treatment for STIs. And these will really, if I can say, might require us to encourage collaborations between, say, researchers and pharmaceutical companies and public health agencies like WHO. We also need to implement maybe regulations, implement and enforce regulations that will control the sale and use of antibiotics over the counter. Let's not just sell them without prescriptions from healthcare providers, because that is the norm that is in Kenya as we speak. We also need to develop policies that will go against this over-the-counter habit of antibiotic sale. Lastly, I can say that we need to develop or explore vaccination programs for preventable STIs so that we reduce the reliance on antibiotics for treatment. So let's encourage, research will bring us more vaccines for these STIs. And so when people are vaccinated, they won't be taking a lot of antibiotics. This will help. The last one will be just community engagements, just like educational programs, community engagement to help communities understand the implications of MR and working with them in preventive measures. Thank you.
Thank you so much. And thank you to all of our presenters today for such a phenomenal job. Also, thank you to our attendees for sticking this out with us and for your phenomenal questions. With that, our webinar this morning is over. Of course, the recording and all of the slides will be made available online, and we will send you an email with that information on Monday. So thank you so much, and I hope you guys have a great rest of your day.
Thank you, colleagues.
Thank you so much, Alison. Thank you, everyone.
Thank you, Alison. Bye.
Bye, everyone.
From the 26th until